And then this is also, the lateral muscles composed of the external oblique, the internal, this is the external oblique, the internal oblique, and the transversus abdominis muscle. And they extend across the entire wall of the abdomen. Now, this muscle, there is a primary fascia which is established because of the, what's the time? Because of the fusion of the aponeurosis of these three muscles, the external, the internal, and the transversus abdominis muscle, forming the primary fascia. And this invests on the rectus abdominis muscle to form the rectus sheath. Nauulang kasi ako hindi nga admit coming in late. So, first. The rectus abdominis muscle, the rectus sheath, if the woman now, if the individual is standing and then she starts to lie down, you can see now that the rectus sheath will cover over the rectus muscle. The rectus abdominis muscle, so you have the anterior rectus sheath and the posterior rectus sheath. So these are formed by the aponeurosis of the three muscles in the abdomen. And what is the significance of this? At the posterior rectus sheath, just anterior to that, behind this muscle are vessels. So during the procedure, when opening up the abdomen, as you go to the muscle layer, you tend to separate these muscles in order to gain access into the abdominal cavity. So if you try to split these muscles to the lateral, there is the risk that these vessels may be severed or may be cut. And if this is not identified, this can continuously bleed and causing hematoma, and it can even lead to hypovolemic shock. Now, next is we have to consider the blood supply also of the abdominal wall. So the blood vessels supplying the superficial layer, the skin, subcu, and the mons pubis is from the femoral artery, while deeper are the external iliac artery. So the femoral artery supplies this superficial structure, the skin, including the mons pubis, coming from the femoral artery. And this femoral artery will give off the external pudendal artery towards the mons pubis, the external superficial epigastric artery, and then the circumflex iliac artery. Now, for the muscles and the fascia, because these are deeper structures, the blood supply will be coming from the external iliac artery. And then, we will now go to the generative organs, or the organs on the genital area. So the external generative organs, first we go to the vulva, also known as the pudenda. So you are referring, when you say vulva or pudenda, you are referring to the structures visible from the symphysis pubis up to the perennial body. So this is the vulva, and you are referring here to the many structures that can be seen from there. Now, first structure we can see is the mons veneris. Now, this is fat-filled, overlying the symphysis pubis. During puberty, this is covered by hair, which becomes curly, and then which, according to Tanner staging, becomes coarse and more curly. Now, the hair distribution, you should always take note that for female, it is triangular, while in the male, it is in a diamond shape, which can even extend up to the umbilical area. You have to consider the pattern of the hair in a female, because if this is of different shape, you will now be thinking of hyperandrogenism. Now, later on, moving on, you have here Part of the vulva also, the labia majora. Now, this is a dense connective tissue which is rich in adipose. That's why it is soft. And this is nearly devoid of muscular elements, but it has a rich venous plexus. So the male homologue for the labia majora is the scrotum. Now, this labia majora superiorly, they will be continuous with the mons pubis, while posteriorly, this will form the posterior commissure. Now, the outer surface of the labia majora is covered by hair, of course, while the inner surface is not covered by hair. And it has abundant apocrine and sebaceous glands. Now, medial to the majora is the minora, the labia minora, which is two thin fold of tissue, and this is devoid, of course, of hair and fat. Now, this is richly supplied by nerve endings, and then superiorly, this will divide into two to form the prepuce of the clitoris, and then inferiorly is the frenulum of the clitoris. So, as this structure, uh, as you trace this structure, the labia minora downward, posteriorly, this will form the fork shape. So you should be able to identify the structures carefully, especially when you will be in your clinics. Now, another structure seen in the vulva is the clitoris. Now, this is the principal erogenous organ, and this is found beneath the prepuce and above the frenulum, which came from the labia minora. So, you know, the male homologue of clitoris is the penis and supplied by the internal pudendal artery. Now, another term that you have considered is the vestibule. This is considered as the mature female structure. This is almond shaped, and this is bounded laterally by the labia minora, medially by the hymen. So this is the vestibule. You don't call this area as vestibule, so you have the respective names for those. Now, the vestibule, the significance, it is perforated by openings. There is the urethral opening, the vaginal opening, then there are the opening for the Bartholin's duct, as well as the paraurethral or the skin's duct. Now, another structure you have to check is the Fossa Navicularis. This is the area between the vaginal opening and the foreshape. This is usually seen in nulliparous women. Those women who have not given birth. Previously, in the old books, it was considered as U-shaped when the woman has had history of sexual contact, while it is V-shaped in women who have not had sexual contact. However, this has already been disregarded in the reference is just being described as an area between the vaginal opening and the foreshape. Now, another structure is the Bartholin's gland. Grossly, you cannot see here on the vulva the Bartholin's gland. They are also known as the greater vestibular gland, and this is a major gland. But if we look deeper, the Bartholin's gland are found at 5 and 7 o'clock positions. They secrete mucus, and these secretions will have to pass through the Bartholin's duct. And this duct then will open to this structure, the to an opening which is found at 5 and 7 o'clock position. So you will have to check that. Imagine using the clock position reference, the 5 o'clock position is somewhere here, while the 7 o'clock position is somewhere here. So the ducts here will open to these areas, and there will be production of mucin on that areas. Now, what will happen if there is an infection or trauma on this area, resulting in obstruction of the duct? Therefore, the mucin being produced will not be able to come out of that duct, and therefore there could be swelling on the duct, producing the Bartholin cyst, and if there is secondary bacterial infection, it will become a Bartholin's abscess. Now, there is also the paraurethral glands. These are the ducts of the paraurethral glands, which is lined also by simple mucin-secreting epithelium. Now, this paraurethral, the skin's gland, they also can be inflamed. And if this is obstructed, it will result in a urethral diverticulum. Now, another opening found on the vestibule is the urethral opening. This is the urethral meatus or opening. What is the significance of this? You will become clerks, you will go to the clinics, you will be instructed to insert a catheter on a woman for operation. Make sure that you are putting the catheter on the right hole. Remember, there are 6 openings here on the vestibule. Some may be inserting the catheter through the vaginal canal. Of course, there will be no urine output, or this could be not identified. Some will try to look for the urethral opening here. So it is important that you know the location of the urethral opening. So this is just above the vaginal opening and beneath the clitoris. So make sure you are not poking into the clitoris in trying to insert the catheter because you are causing the woman discomfort. Now, another structure is the hymen. This is an elastic tissue which surrounds the vaginal opening. So this is elastic, collagenous, and the opening of the hymen may vary in size from pinpoint to the one to a size that will admit 1 or 2 fingers. Now, this is just for information that the appearance of the hymen will not determine whether the woman is virgin or not. Now, it has nothing to do with virginity. Now, another structure is the vagina. This is a musculo, so it's made up of muscle and a membranous structure. This extends from the vulva up to the uterus. Now, on lateral view, the vaginal opening when the woman is standing is directed upward and a little bit backward. Now, anteriorly is the urinary bladder, and posteriorly, related to that, is the rectum. Now, the upper part of the vagina is derived from the Mullerian duct, while the lower portion is derived from the urogenital sinus. Now, the vagina is separated through septum from the bladder, through the vesicle, this is the bladder, vaginal septum. And then there is also a septum which separates the vagina from the rectum, which is the rectovaginal septum. On the upper part is the rectum uterine pouch, which is separating the upper fourth of the vagina from the rectum. Now, anatomically, the anterior and the posterior walls of the vaginal canal, they lie in contact. It's not open, but they lie in contact. And you can see that the anterior vaginal length is shorter as compared to the posterior vaginal length. So you have here the 8 cm anteriorly and 10 cm posteriorly. The lining epithelium of the vagina is stratified squamous, non-keratinized. Now, this is a tubulo-muscular structure and it has no glands. But this vagina is lubricated by transulates coming from the plexus subepithelial capillary plexus. So there are no vaginal glands. Now, the fornices, the vagina also has fornices on the upper end of the vaginal wall. So you have here anterior, posterior, and lateral fornix. So the anterior fornix, if you look at the woman from the lateral view, then there's the posterior fornix, then 2 lateral fornices. Now, what is the significance among this is what is more significant is the posterior fornix, because then when the woman is lying down, this area becomes an area which will provide surgical access to the peritoneal cavity. So you can poke a needle here and then check if what is the what for any fluid coming from the abdominal cavity. Because if there is a ruptured viscus, you might be able to get blood. If there is infection, you may be able to extract pus, and it will guide you in your management of your patient. Now, the blood supply to the vagina is extensive, no? So, from the proximal area, it is mainly coming from the vaginal artery. So, this is the vaginal artery, which supplies the proximal part of the vagina, and then the distal part is covered by the internal pudendal artery. Now, posteriorly, at the back of this is posteriorly is the, because this is posterior view, is the middle rectal artery, and anteriorly there is also the inferior vesical artery. So you can see that the vaginal area has an extensive blood supply because it can expand later on. Now, if we remove the structures overlying the vulva, the skin, the subcutaneous area, we will now be seeing the perineum. No? So this is the diamond-shaped area between the thighs. If we are going to check the bony boundaries of the perineum, it is the symphysis pubis anteriorly, laterally by the tuberosities, ischial tuberosities, and posteriorly by the coccyx. That's why it's a diamond-shaped structure. Now, it has a major blood supply, which is coming from a pudendal artery, and then the inferior rectal and the posterior labial artery. Now, this perineum has two triangles. You have here the anterior triangle as well as the posterior anal triangle, previously called the posterior triangle. It's the anal triangle. Now we go to the anterior triangle. So the boundaries again, anteriorly, superiorly is the rami of the pubis, laterally by the ischial tuberosities, and posteriorly a muscle crosses there. So this is the superficial transverse perineal muscle which forms the posterior boundary of the anterior triangle. Now, this anterior triangle of the perineum is further divided into a superficial space and the deep space. And the dividing structure or membrane is called the perineal membrane. This whitish structure is the perineal membrane. Above the perineal membrane is the area called the superficial space of the anterior triangle, and beneath that is the deep space of the anterior triangle. Remember again that we are now talking beneath now the skin and the subcutaneous area. So for the superficial space of the anterior triangle, this is bounded deep by the perineal membrane and superficially by the colles fascia. So this colles fascia is again continuous with the fascia on the abdominal wall. So the advantage of this area on the anterior triangle is that this is a closed compartment, so that if there is any infection or bleeding that may occur here because of a ruptured blood vessel, the bleeding can be confined only to this space. Now, what are the contents on the superficial space? So you can see here the muscles. This is the ischiocavernous muscle, the bulbocavernous muscle, and the superficial transverse perineal muscle. There is also the clitoral body, the vestibular valve, the ducts of the Bartholin's gland, as well as the nerves, the pudendal nerves. So we go to these muscles first. So I mentioned the ischiocavernous and the pulvocavernous muscle. These two muscles help maintain clitoral erection, considering that they are connected to the clitoral area. So the bulbocavernous muscle will help constrict the vaginal lumen, and it aids in the production of the mucus coming from the Bartholin's gland. Now, the significance of this muscle is that during childbirth, this is the vaginal canal. If this muscle will be transected during an episiotomy, then it can also cause indyspareunia. Though another muscle is the superficial transverse muscle, and this contributes to the perineal body. Now, another structure in the superficial layer of the anal triangle is the vestibular valve. This is an aggregation of vessels here, and this is lying beneath the muscle, this bulbocavernous muscle. Now, what is the significance of this vestibular valve? Now, this is an aggregation of veins. This is the vaginal opening. During childbirth, there is stretching of this vulva, and this beneath this are the vestibular valve. So there could be stretching, and this could be injured or may even rupture, and this will result in vulvar hematoma. And if this is not addressed, this can cause hypovolemic shock or even death. Now, beneath the superficial space of the anterior triangle is the deep space. So the deep space, this is now seen once the perineal membrane is removed or is cut. So this now extends into the pelvis. So this is the perineal membrane. So you can now see the deeper area if the woman is standing. While if the woman is in supine position, you remove the perineal membrane and you can see the deep space of the anterior triangle. And what are the contents? Parts of the urethra, parts of the vagina, and of course, the muscles surrounding these structures. You have the compressor urethrae as well as the external urethral sphincter. Now, below the anterior triangle is the posterior triangle, also known as the anal triangle. So this is bounded. The apex is the coccyx, and laterally are the ischial tuberosities as well as the sacrospinous ligament. Now, what are the contents now of the posterior? So this is the anal triangle. Therefore, there's the anal canal, the anal sphincter, the ischiorectal fossa, as well as the branches of the pudendal nerves and vessels. What is this ischiorectal fossa? This is this one. These are two fat-filled wedges or spaces which are found on both sides of the anal canal. Another picture that we can clearly see that ischiorectal fossa are this yellowish structure. Now, they are comprising the bulk of the posterior triangle, and this provides support to the surrounding structures or organs. So that during defecation, this allows, this fossa will allow the distension of the rectum as well as stretching of the vagina during delivery. Now, the disadvantage or the characteristic for the ischiorectal fossa is that it can communicate posteriorly from one side to the another side. So that if there is any infection on one side or if there is malignancy, it can spread from one side of the anal canal to the other in the deep perineal membrane. So, another structure in the posterior triangle is the anal sphincter. So if this is the anal canal, this is surrounded by muscles which we call the sphincter. So this is the internal anal sphincter. This is the external anal sphincter. And this also, remember, this is the anal sphincter, the anus, and this is the vaginal opening. so that during vaginal delivery, there is one or both of the sphincter may be torn during this delivery. And especially if it is the internal anal sphincter which is severed, it may not be seen externally and may not be detected at once. Now, another structure is the perennial body. This is a web-shaped fibromuscular tissue in the midline. This is also known as the central tendon. And this perennial body is short, especially for Filipinos, because it just measures 2 centimeters in distance between vaginal opening and the anal opening. Now, this is this perennial body has muscles attached to that. You have here the bulbocavernous muscle, the superficial transverse perennial muscle, and the external anal sphincter muscles. So this is the central tendon, also known as the perennial body. And this is of extensive muscular support, therefore it provides significant perennial support. So during labor and delivery, this is the perennial body. This is only 2 centimeters. And during an episiotomy, this can be incised. That's why a mediolateral episiotomy is preferred, because it avoids the anal sphincter. Because if you do a median episiotomy during the delivery of the woman, there is the risk that you will cut through the external anal sphincter, and therefore this will result in bowel incontinence. So the perennial body has a lot of functions, because it will support the rectal area, the vaginal area to prevent, and it will also provide continence on these areas. Now, if you move deeper into the pelvis, you will now see the pelvic diaphragm. Now, we will now change our view on the pelvis. We will have to look from the woman, from the head part going down, looking down. So this is the symphysis pubis. This is the sacral promontory. Now, imagine the woman is lying down and supine. So the pelvic diaphragm is better visualized as such. This is a broad muscular sling which provides substantial support to the pelvic viscera. And this pelvic diaphragm is composed of the levator ani muscle, which is comprised of the puborectalis muscle, the pubococcygeus muscle, and the iliococcygeus muscle. So these are forming the levator ani, and then another muscle here is the coccygeus muscle. Now, because of this connection, puborectalis, it will also help in controlling the urination, because this is the urethral opening, the vaginal opening, and the anal opening. So it will control the urination, the parturition, and help also maintain fecal continence. It also helps the abdominal and the pelvic organs from prolapsing. And this levator ani muscle will facilitate the distribution of intra-abdominal pressure when you are coughing. So even if you are doing your TikTok, your organs will not prolapse down, because it is supported by the levator ani muscle. Among the levator ani muscles, it is the pubococcygeus muscle, which is at risk for being damaged during vaginal delivery. And when this is overstretched, being a skeletal muscle, it will now predispose the woman to pelvic organ prolapse. So moving on, we will now look at the internal organs. So the uterus, this is a pear-shaped organ, which during the non-pregnant state is a pelvic organ. So you can see this is the pelvis, this is the umbilicus. So the uterus is basically a pelvic organ. So this is also found between If this is the uterus, the vaginal opening, anteriorly is the urinary bladder, and posteriorly is the rectum. Now, this is also covered by a peritoneum. And the uterus on the lower portion is the recto-uterine pouch or the pouch of Douglas. Now, the anterior uterine wall is covered by peritoneum, but it is reflected into the urinary bladder, which we call the vesico-uterine fold or pouch. The uterus has two parts which are unequal in size. This is the body or the corpus, while this is the cervix. Now, there is also the isthmus, which is the portion between the internal os and the endometrial cavity. That is the isthmus. And what is the significance of the isthmus? During pregnancy, it forms the lower uterine segment. What is the size of the uterus? For those women who have not given birth, it is 6 to 8 centimeter. So you have here, and the size is equivalent for the fundus and the cervix. They are of equal size. Once the woman has already given birth, the size of a normal uterus is quite larger, but it is still a pelvic organ. Now, the cervix, this is the fusiform portion of the uterus. So the cervix is still a part of the uterus. And it open at each end by small aperture. So there is the internal os and the external os, which you may be talking later on much in the clinics. Now, the cervix is mainly composed of collagen. That's why it can hold the pregnancy normally up to 9 months. Just imagine we were inside the uterus then. We started from here. So the cervix is made of collagen because it makes the uterus unyielding. So it can hold the pregnancy for up to 9 months under normal circumstances. So the muscle component of the cervix is only around 20%, unlike the body of the uterus. Now there is also the portio vaginalis, which is at the lower portion of the cervix, and the supravaginalis, which is in the upper segment of the cervix, which lies near the vaginal area. The opening of the cervix will matter whether the woman has given birth or not. If the woman is nulliparous, it is oval. Look at the aperture. It is small and regular. When the woman has already given birth, it becomes transverse or slit-like, dividing now the cervix into an anterior lip and a posterior lip. And because this could have been torn during delivery, which later heals and forms nodulations. Now, the cervical os also has the ectocervix and the endocervix. So this may have an implication in metaplasia, which can be discussed in your advanced lectures in obstetrics. Now, the lining epithelium of the uterus is the endometrium. So the layers of the uterus, you have the serosa from the external, then the myometrium, and the endometrium. The lining epithelium, there are also glands here, and the blood supply to the uterus mainly comes from the uterine artery, which is a branch of the hypogastric artery. So I mentioned kanina, the uterus has the serosa, the myometrium, and the endometrium. And the blood supply is the uterine artery. So once the uterine artery enters the uterus, it gives off an arcuate artery, which further becomes radial artery and then basal artery. So you will see that the branch of the uterine artery found on the myometrium, while on the endometrium, the innermost layer of the uterus, it is mostly supplied by the spiral artery. So the spiral artery which supplies the endometrium, you know that the endometrium is further divided into the functional zone and the basalis zone. So the functional zone is further divided into the zona compacta and the zona spongiosa. And this is the functional layer which is sloughed off during menstruation, while this basalis layer of the endometrium is the one that regenerates. This is supplied by this coiled artery. And therefore, this spiral artery or the coiled artery plays much role in the menstruation. Now, the myometrium, most of the uterus is composed of the myometrium. So the uterus is mainly muscular. It is composed of smooth muscle fibers. And beneath these are the vessels, the myometrial vessels, which are interlaced in the myometrium. So that this has something to do in the control of bleeding during labor, during delivery, and postpartum. Because if the uterus will contract, it will seal off these open sinuses on the myometrial vessels, and therefore the bleeding will be stopped. So remember that during delivery, vaginal bleeding can be torrential or very profuse, which can also lead to death. And this is one of the major triad of maternal death, hemorrhage. Therefore, it is important that the uterus should contract after delivery in order to seal off these vessels to stop the bleeding. The uterus is also supported by ligaments. They are thickenings of the retroperitoneal fascia, and they support the uterus, and they put the uterus in place. So one of the ligaments here is the round ligament. So this originates below and anterior to the fallopian tube. Anatomically, this is the anterior. You are looking at the structures anteriorly from front. So this is the fallopian tube. This is the ovary. The round ligament is found originates from the anterior portion of the fallopian tube. This is found anterior and inferior to the fallopian tube, and this terminates into the labia majora. So this is the only ligament which goes out of the pelvis to go to the round ligament. And the significance of this ligament, aside from supporting the uterus, is that this becomes a landmark when you are going to do tubal ligation. When you want to sterilize or do ligation of this fallopian tube, you will have to check that the fallopian tube is found upper and posterior to the round ligament, because there is the chance that you might mistake and ligate this structure instead of the fallopian tube, and therefore your patient will become pregnant again because of failed sterilization. Now, another ligament is the broad ligament. This is a wing-like structure. So this is the round ligament, which extends from the lateral margin of the uterus going to the pelvic side walls, dividing the pelvic cavity into anterior and posterior components. So this wing-like structure of the broad ligament has an anterior leaf and a posterior leaf. And this drapes the structures like the mesosalpinx, the mesoteres, and the mesobarbium. Now, another ligament is the infundibulopelvic ligament, or the suspensory ligament of the ovary. So this supports the ovary towards the pelvic side walls, and it is traversed by vessels. So the significance of this is that this ligament is also severed or cut when you want to remove the uterus or the ovary for a gynecologic problem. Now, another ligament is the Cardinal Ligament or the McEnroe ligament. This is the transverse cervical ligament, which is found near the ureter. So again, this is a very strong, in fact, this is considered as the strongest ligamentous support of the uterus. Now, what is the significance? Because this is near the ureter. If you are going to remove the uterus for a gynecologic procedure or an emergency obstetric procedure, you are going to do hysterectomy. You make sure when you have to sever this ligament here, the risk that you will be hitting the ureter is there. Therefore, you have to know the location of the ureter, because if this ligament is being cut and you also cut the ureter, your patient will have no urine output. So another ligament is the uterosacral ligament. So the uterosacral ligament. And this provides attachment of the uterus towards the uh, posterolateral portion of the pelvis. Now, this is, you are looking here at the uterus from the posterior view, since you can see the ovary. Now, I already mentioned the blood supply to the uterus, which is coming from the uterine artery. Now, this is a branch coming from the internal iliac or the hypogastric artery, and this uterine artery provides also branches towards the fallopian tube, to the ovary, and to the vagina. Now, the lymphatics of the genital tract. So if the lesions are found on the vulva or the lower part of the vagina, they drain into the inguinal nodes. That's why it is important during your physical examination, you also palpate the inguinal lymph node. If the lesion can be, if there is a problem on the upper part of the vagina, including the cervix and the uterus, the lymphatic drainage will also now go to the sacral nodes. Now, if there is a problem in cases of ovarian tumors, cancer, you also have to check, because there's drainage into the para-aortic nodes. That's why when doing procedure for ovarian malignancy, you also trace the lymph node. Now, for the innervation of the pelvis, it has the sympathetic and the parasympathetic portion. So the sympathetic comes from the thoracolumbar, T10 to L2, and the parasympathetic is the craniosacral. So the innervation to the pelvis starts as a superior hypogastric plexus or a presacral nerve, which is derived from T10 to L2. This is found just anterior to the bifurcation of these vessels, and then it will now derive past divide into the right hypogastric nerve and the left hypogastric nerve. As this moves toward the side walls of the pelvis, it will also combine with the parasympathetic portion to form the inferior hypogastric plexus. Kanina it's superior, then it becomes inferior hypogastric plexus, because it will also involve S2 to S4. Now, this plexus will now divide into three. It will have the vesical plexus supplying the bladder, innervating the urinary bladder. There is the middle rectal plexus, innervating portion of the rectum as well as the posterior vagina. And then there is the uterovaginal plexus, because it will now innervate the uterus and part of the vagina, which is called the Frankenhauser's ganglion. This also may innervate a portion of the fallopian tube. Now, these vessels, the innervation of the pelvis may have something, maybe have its implication during labor and delivery. Now, another nerve involved in obstetrics is the pudendal nerve, obstetrics and gynecology, which is derived from S2 to S4. Now, this pudendal nerve will leave the pelvis through the greater sciatic foramen to go to the luteal portion of the lower limb. And then it will enter back to the pelvis through the lesser sciatic foramen and then pass through the canal, the pudendal canal, where it will give off three branches to innervate the pelvis: the inferior rectal nerve, the dorsal nerve of the clitoris for the woman, and then the branches of the perineal perennial nerve. So these structures, this pudendal nerve will provide sensory innervation to the pudenda, the vulva, vestibule, clitoris, or in other words, to the external generative organs of the female. So they are coming from the pudendal nerve. Now, what is the clinical correlation about this pudendal nerve? Since it exits the pelvis through the greater sciatic foramen, now this is the greater sciatic and the lesser sciatic. Between that is the ischial spine, in the bony pelvis. Now, during labor and delivery, anesthetic block can be done through blocking the pudendal nerve so that the labor and delivery will be less painful. Now we go to the adnexal structure, the fallopian tube. So after the uterus is the fallopian tube, which is a tubular extension coming from the cornu, from the uterine cornu, measuring 8 to 14 centimeters in length. And it has different parts and mainly the function is to pick up the ovum released coming from the ovary so that it can enter the fallopian tube. And there it stays, the fertilized ovum stays on the fallopian tube, wait for the sperm to come in for fertilization. So another function of the fallopian tube is a physical environment for conception, and then later on, transport this fertilized ovum towards the uterine cavity. Now, the fallopian tube is further composed of the interstitial, the isthmic. The interstitial is the structure embodied within the muscular components of the uterus. Then there is the isthmic, then there is the ampullary, which is considered the wider portion, and this is the area for fertilization. Then we have the fimbriated end. Now, one of these fimbria, or the finger-like projection, there is one finger-like projection which is actually longer than the others, which we call the fimbria ovarica, because it will tend to catch the ovary from the ovum released from the ovary. Now, the fallopian tube has different component layers. So you have here the mesosalpinx, which is the serosal area, then the myosalpinx, which is the muscle layer, and then the endosalpinx. Now, the mesosalpinx is the serosal outermost, lined by single layer of mesothelium. The myosalpinx is the muscular area composed of the inner circular and the outer longitudinal, which also contracts, therefore trying to propel the fertilized ovum also into the uterine cavity. Now, the endosalpinx or the lining epithelium is composed of columnar ciliated, and it is also secretory type. Now, this endosalpinx, the lining epithelium of the fallopian tube, unlike the other structure, has no submucosa. It is in contact directly with the muscle, and it has plays also a role in cases of ectopic pregnancy. Now, the ovary is another adnexal structure. So when we say adnexa, we are referring to the structures in the fallopian tube and the ovary. So the ovaries are gonadal structures and they vary in size. So it is important when you know the normal sizes, like the fallopian tube, what's the normal length, and then the ovary is only 2.5 in length by 1.5 in width and thickness of up to 1.5 cm. So an ovary is normally not palpable, especially that these are pelvic organs. So the ovary, of course, along with the uterus, it is also supported by ligaments. So this is suspended because the ovary is suspended in the pelvic wall and uterus, and it has the ligament. Laterally, you have the suspensory ligament, then the medially the ovarian. The suspensory ligament, also known as the infundibulopelvic, then you will have the ovarian ligament, and inferiorly there is the broad ligament. Now this ovarian structure rests in a fossa called the Waldeyer's fossa. Now the ovary, normally it has the cortex and the medulla. The cortex is the outer portion which looks smooth or even dull, and the whitish color here is referred to as the tunica albuginea. It is lined by a cuboidal epithelium, and this is the cortex which contains the oocytes and developing follicles. What is the significance of this? If you are going to remove the fallopian tube, which could be adherent to the ovary, make sure you don't cause trauma to this ovarian cortex because the follicles and the oocytes are there. If you destroy this and there will be no more follicles, then your patient may no longer be able to get pregnant. Now, the inner structure is the medulla. It contains more of the vessels and the fibers. What is the blood supply to the ovary? It is coming from an ovarian artery, which is a direct branch from the abdominal aorta. So if the uterine artery is derived from the internal iliac artery, the ovarian artery is derived from the uh, abdominal aorta. Now, venous drainage from the ovary, from the right ovarian vein will have to drain through directly to the inferior vena cava, while the left ovarian vein will drain first to the left renal vein, then going to the vena cava. Now, so aside from the different organs of the female reproductive tract, we also consider in the anatomy the musculoskeletal areas or the pelvic structure for females. So the pelvic bone, there are four bones of the pelvis. There is the sacrum, the coccyx, and two innominate bones. Innominate, or there are no names because the innominate bone is composed of the ilium, the ischium, and the pubis. This is the ilium, the ischium, and the pubis. Now they are joined together by synchondrosis. Now, the pelvis is further divided into a true and a false pelvis. So, what is obstetrically important is the true pelvis. The false pelvis is above the true pelvis, which is, this is the linea terminalis, the structures above this. So, above the pelvis is called the false pelvis, which is bounded posteriorly by the lumbar vertebrae, laterally by the iliac fossa, and anteriorly by the abdominal wall. That is the false pelvis. And this supports the abdominal structures. Although during pregnancy, in the later part, when the uterus becomes an abdominal organ, the false pelvis now will play a role in supporting the gravid uterus. Now, during labor and delivery, the false pelvis, because it is bounded anteriorly by the abdominal wall, will help to guide the fetus into the true pelvis. So where is the true pelvis? So the true pelvis is below the linea terminalis. So posteriorly, it is bounded by the sacrum, and laterally by the ischial bones and the sacrosciatic ligament. So this is the ischial spine, and in front it is bounded by the pubic bones and the ascending rami of the ischial bones. Now, these side walls converge. The side walls of the pelvis converge. Now, So the pelvis has different diameters, no? There is the composed of four imaginary planes because you just think about this pelvis as to their plane based on the level of the pelvis. So there is the plane of the pelvic inlet, the plane of the pelvic outlet, and the plane of the mid pelvis. So the mid pelvis is the plane of the least pelvic dimension. So among the three, this is also important, the mid pelvis, because it is has the least dimension. Now, the plane of greatest pelvic dimension has no obstetrical significance. So you will just think about the inlet, the outlet, and the mid pelvis. This is in relation to labor and delivery later on. Now, the pelvic inlet, this is also known as the superior straight, and this is bounded posteriorly by the sacral promontory and the alae or the wings of the sacral promontory posteriorly, laterally by the linea terminalis, and anteriorly by the horizontal rami of the pubic bone and the symphysis pubis. That is the pelvic inlet. Now, what is the shape? Normally, it is nearly round, or what we call the gynecoid pelvis, which we want for females. Now, the pelvic inlet, if you look on from the lateral view, this is the sacral promontory, this is the symphysis pubis, so this is the pelvic inlet. The mid pelvis, or the plane of least pelvic dimension, is this structure, and this is the pelvic outlet. Now, the pelvic inlet, we concentrate first on the pelvic inlet. It has four diameters. You have here the antero-posterior diameter, you have the transverse diameter, and two oblique diameters. So there are four diameters of the pelvic inlet. Now, focusing on the AP diameter or anteroposterior or AP diameters of the pelvic inlet, it is composed of three conjugates, which are obstetrically important. So what are these conjugates? If you see this, now this one, the woman, we look here from above, while this one, lateral view, the woman, we assume is lying down. This is the symphysis pubis. This is the sacral promontory, and then the coccyx. So the anteroposterior diameter of the pelvic inlet is composed of three conjugates. We have here the true conjugate, then you have the obstetrical conjugate, and the diagonal conjugate. Now we go first to the first conjugate, the true conjugate. This is the distance between the upper margin of the symphysis pubis to the sacral promontory. This is the true conjugate of the AP diameter of the pelvic inlet. Now, another conjugate on the AP diameter of the pelvic inlet is the obstetric conjugate. This is the distance from the mid portion of the symphysis pubis to the sacral promontory. Now, this obstetrical conjugate represents the shortest antero-posterior diameter of the pelvic inlet through which the fetal head will pass through. And then it should measure 10 centimeter or more for the fetal head to pass through during delivery. So if this is short, less than 10 cm, then the chance that the fetal head diameter cannot pass through this structure. So the third conjugate of the anteroposterior diameter of the pelvic inlet is the diagonal conjugate. This is the distance from the lower margin of the symphysis pubis to the sacral promontory. And among the three conjugates of the pelvic inlet, this is the only clinically measurable AP diameter of the pelvic inlet. And how is it done? So when you examine a patient, clinical estimation of the diagonal conjugate. So this is the symphysis pubis, This is the sacral promontory. This is the coccyx. With the woman lying down during labor and delivery, you want to determine the pelvis. Is it adequate or not? The pelvic inlet. So when you say pelvic inlet, you are measuring the distance from the symphysis pubis and the sacral promontory. So using your two fingers, index and the middle, you insert your finger into the vaginal canal and reach for the sacral promontory. And then take note the distance also where your hand reaches the symphysis pubis. So you measure that. Now, if that measures 11.5 and above, you subtract 1.5 to 2 centimeter in order to obtain the obstetric conjugate, which is the shortest AP diameter of the pelvic inlet. So if this is 11.5, then you will have a 10 centimeter obstetric conjugate. Because if you have a 10 cm diagonal conjugate, you subtract 1.5 to 2, you will obtain around 9 or 8.5 to 9 cm of obstetric conjugate, and therefore you will now say that the AP diameter of the pelvic inlet is contracted because you need it to be, the obstetric conjugate needs to be at least 10 centimeter for that fetal head to pass through. Now, that was the antero-posterior diameter of the pelvic inlet. You have the three conjugates. Now, another diameter is the transverse diameter of the pelvic inlet, which is the greatest distance between one linea terminalis to the other side. And this measures 13 centimeter. You do not usually encounter any problem in the passage of the fetus through the transverse diameter of the pelvic inlet because it is 13.5 cm. Then there are two oblique diameters, the right and the left diameters, extending from the sacroiliac synchondrosis to the iliopectinal eminence. And it is also 13 centimeter. So there is usually no problem for the passage of the fetus during delivery, labor and delivery in relation to the pelvic inlet. Now, as we move downward, there is now the another part of the pelvis which we call the mid pelvis. Now, this is the plane of least pelvic dimension. So, this is measured by getting the distance from one ischial spine to another. So, for the mid pelvis, the landmark of the pelvis now is the ischial spine. Previously, the pelvic inlet, the landmarks are the symphysis pubis and the sacral promontory. Now, for the mid pelvis, it is now the ischial spine which becomes the landmark. So, you measure the transverse diameter from one ischial spine to another. The interspinous diameter should be at least 10 centimeter because you will later learn that during the process of labor and delivery, the fetal head that will have to pass through will be around 9.8 or 9 cm. And therefore, for that baby to pass through the mid-pelvis, the interspinous diameter should be 10 centimeter. So this also is important in the cardinal movement of the fetus. Now, so if you want to palpate for that ischial spine, you will see it is in the mid-pelvis and it is a bony prominence. If this type of ischial spine is prominent, if you have a prominent ischial spine, then there is the risk that the diameter from this area to this area may be less than 10 centimeter. So if this is prominent, you will now be guarded on the during the labor and delivery process of your patient because she might have dystocia later on. Now the third part of the pelvis is the pelvic outlet. Actually, this seldom obstructs vaginal delivery. So we go now to the different shapes of the pelvis. So this was classified by Caldwell and Molloy. So they divide the pelvis into the anterior segment and the posterior segment by drawing a line through the greatest transverse diameter of the inlet. So you have here the four shapes. You have the gynecoid, which is the most common for the female, and this has good obstetrical outcome for vaginal delivery. Then there is the anthropoid platypilloid because the transverse diameter is wider than the AP anteroposterior diameter. And then there is the android or the heart shape so that the transverse diameter is shorter also than the AP diameter. And this is more common in the male type of pelvis. So if the female will have this type of pelvis, the android type, there is the risk that she will have dystocia during her labor and delivery, and she might end up having a cesarean delivery. Now, the shapes of the segments, so the anterior segment will determine the tendency of the pelvis, while the posterior segment will determine the type of pelvis. So mostly they are mixed type, but common for the female are the gynecoid, for the male are the android. So this is the last slide for my lecture. Are there any questions with regards to the anatomy? So if there are none, because there's nobody who's responding to me, so I might as well end this lecture. So thank you, everyone. Good afternoon.